Please start. We are live.
Okay, so good evening, everyone. Good evening, faculty and attendees. So it's a great pleasure to welcome you all. So the topic is optimizing treatment outcomes in lung and breast cancer. So today we can discuss about lung cancer. So I would like to invite Dr. Ankit Batra, sir. He is an assistant professor, medical oncology, CRIHIMS, Dehradun. So it's over to you, sir.
Yeah, thank you, Vitika. So I would like to extend a very warm welcome to all our panelists, speakers, and discussants. It gives me a great pleasure to organize this webinar on optimizing treatment outcomes in lung and breast cancer. So today we'll be discussing about lung cancers. What are the newer upcoming things, newer trials? What are the evidences for that? And for that, we have a lot of eminent oncologists from around the country, and without wasting much time, I would like to invite our first speaker. She's Dr. Richa Nathani. She's a consultant medical oncologist at Dr. Lal Path Labs, New Delhi. And we'll begin our sessions with newer sequencing, like RNA sequencing for detecting gene fusions in non-small cell lung cancers. We all know that previously a lot of newer molecular things are being upcoming, and we have been technically focusing more on DNAs, but we know that a lot of things are being missed when we are not looking on the RNA or in combination of both. So we'll be getting insights from Dr. Richa Nathani that how RNA sequences can help us in detecting DNA fusions in non-small cell lung cancers. So over to you, ma'am.
Thank you for the kind introduction, sir, and also thank you for the opportunity. Without wasting much time, I will.
Ma'am, your voice is little bit slow. Can you please get it a bit loud?
So, is my screen visible?
Yes, ma'am, your slide is visible.
So, yes, today's topic optimizing treatment outcomes. Before going to the treatment, we would like to see what the lab has to say about the non-small cell lung cancers. So, we all know there's a huge spectrum of oncogenic drivers when it comes to non-small cell. And the spectrum varies when it comes to Western and Asian population. Yes, the big blue ocean that you see here is EGFR, so which is higher in Asian population compared to Western. But today we are not going to talk about the blue ocean. While we will discuss about the small rainbow there, which has equal proportion in both Asian and Western population. This rainbow may be very little and has a very low percentage, but yes, they all are targeted. So we will see which are those. The basic workup first that we'll discuss, whenever a biopsy, lung biopsy is diagnosed, we look for the classic neuroendocrine component and also the glandular and squamous morphology, which undergoes IHC, and then it is subcategorized into either squamous with the glandular component adenosquamous and maybe mixed, followed by if it is non-small cell NOS or TTF1 positive favoring adenocarcinoma, or sometimes TTF1 plus P40, that is adeno plus squamous component, or purely squamous. Now, this major chunk that we see here, along with PDL1, is supposed to undergo comprehensive molecular testing. Now, why do I say this comprehensive lung molecular testing? Because the current recent guidelines for every newly diagnosed patient that we come across should undergo EGFR, ALK, ROS1, RET, MET, NTRK, ERBB2, KRAS, BRAF, along with PDL1, and also for other resistance mutations, if any. Likewise for the relapsed case. Now, these are the testing guidelines and also the treatment guidelines. Also, the latest treatment guidelines, because this testing is important, because they all are targetable, especially the rearrangements which are not much talked about, like the ALK, ROS, NTRK, MET, and RET. So the most common fusions that we see in Indian population is the ALK, followed by ROS and MET, and also some fraction of red. Others can be NTRK1, 2, and 3. So we'll discuss each one of them briefly. We all know there is a timeline, huge timeline starting from 2001 August, wherein crizotinib, the first line therapy for ALK, and this all has increased till 2022 and beyond that. All these targetable drugs with starting from 2011 August, crizotinib, followed by April we had ceritinib, and so on and so forth. Coming to the most common fusion that we come across is the ALK fusion. 90% of the time, this fusion is seen with the fusion partner EML4. In the EML4, there are variants. These variants can be 1, 2, 3A, 3B, 4, 5A, 5B, 6, 7, 8, AB, A, and 8B. Most common are the top 3 variants. Now, why do we have these subvariants? These variants are basically because it's the exon 13 and exon 20. Exon 13 of EML with exon 20 of ALK. That is the most common variant. Accounts for 33% of the recent studies. Likewise, EML4 to EML20, they have exon 20 of EML and exon 20 of ALK. They both have a fusion. This variant, the variant 1 and variant 2 are the most commonest. Followed by is 3A, 3B together, comprised of 29%. Now, it is the stability of the variants. Like 1 and 2 are more unstable, so they'll be more sensitive towards TKI. While the more stable ones, they will be resistant. Coming to the ROS fusion. ROS, when undergoes fusion with its commonest partners, the CD74 ROS1, this and the others, when it is SLC3A4A2 or EZR, these all lead to activation of all the downstream signaling pathways, which lead to the tumor invasion, proliferation, survival, migration, metastasis, and also increasing its translational capacity. Now, though it is targetable, but sometimes it's not a cakewalk for them because there are resistance mutations that hinder the effect of the TKI. The most common ones that we come across are the G2032, followed by D2033, and so on. Coming to the next fusion, that is the RET fusion. Now, the RET fusion has multiple fusion partners. The most common one is the KIF5B, also the CCD6, NCOA4, and others. Though RET itself is less common, but it also undergoes dimerization and phosphorylation when there is a mutation, most commonly found in the tyrosine kinase domain, in the codon E768 to 918, anywhere between that. Also, it can be in the transmembrane or the juxtamembrane region of the RET gene. Next, coming to the common mutation, this gene MET, which is located on chromosome 7, it undergoes not only fusion, but also there is amplification of this gene. Now, this mutation is tricky. There is this fusion, that is exon 14 skipping that we call. It's nothing but exon 13 and 15 they fuse, so that the exon 14 is skipped. Now, this is the result of a mutation at the splice site. So, this mutation can be detected by DNA-based means, wherein you find most commonly a splice site mutation, like you see here. The G is converted. The G located on the reference has been changed to A. So, this splice site mutation leads to skipping of exon 14. Though you can see the mutation at the DNA level, but for the fusion part, you have to look at the RNA-based versions, wherein the mRNA of the transcript shows exon 12, 13, 15, and 16. So, we have a 14 skipping here. So, this fusion techniques should be done at the DNA level, and I support this with a recent Caris difference submitted by Caris, that says RNA is superior method of gene fusion analysis. And they say this on the basis of a study conducted on 2,500 samples of non-small cell using standard DNA based, of which 232 lacked an oncogenic driver. But on RNA sequencing, they found 15.5% had oncogenic driver. And the most common was the ROS1, which is missed on DNA sequencing and which is actionable. So this is the reason we advise DNA as well as RNA when it comes to fusion. So how does this fusion gene assay workflow happen in a lab? With the FFP blocks that we receive, undergoes assessment for tumor cellularity. With the adequate tumor cellularity, there undergoes extraction of RNA. The input nanogram is 20 nanogram, which undergoes library preparation and reverse transcription, which leads to production of cDNA, which after that undergoes amplification after a series of TCRs and with their custom panels of primers. Adapter ligation, barcode, and library enrichment is done, which undergoes sequencing. This sequencing data is then analyzed using the bioinformatics pipeline. After the bioinformatics, this data undergoes alignment, goes for QC check, and also quantification of the fusion transcript. Now, how do we visualize? Visualize these fusion transcripts on an integrated genomic viewer, wherein we look at the fusion, if it is really there or it is a pseudo call. Like if there is an EML and ALK fusion, wherein the mRNA, there will be a fusion of the transcript which amplifies. Then we look at the amplification zone, if it is covering the region of the transcript or it is on the adjoining areas. So there can be false when the fusion does not lie in its location. So coming to some real world data, it is from our lab. So this is the data that we have pulled in for 1 year. We had around 1,700 samples, of which 10% were unfit due to low tumor cellularity or inadequate tissue. So of these, lung 1638, which passed the first step of QC parameters, of which primary were 65.4 and metastatic were 34.6. The most common metastatic sites were the lymph nodes and followed by pleura, and together the distant metastatic sites were 12.6. Commonly metastatic sites were bone, followed by liver, brain, adrenal, kidney, and others. But when we looked into the spectrum of the oncogenic drivers, we found the fusions were around 10%. And the rest were mutations. Yes, EGFR and KRAS, we had concordant data with the available data that is there. So when we looked at the fusions, we found that the most common was ALK, comprising of 5.5%, followed by MET and ROS. And NTRK was around 0.5% and RET was around 0.8. The multiple fusion partners that we saw with them, EML-ALK had the most common, that is exon 1320, 69%, followed by 620 and 2020. So we have this type A, type 1, type 2, and type 3A. MET, which was 22.8%, has nothing but exon 14 skipping mutation with it, while ROS has several partners, the most common being the CD74-6, and followed by CDC and SLC-A342. RET had only single fusion partner in our data, that was KIF5B, and NTRK was found with ETB6. So from the lab perspective, if I want to summarize how are the testing being done for non-small cell, there is a paradigm shift. Earlier, it used to be only single gene test, which had EGFR and ROS, and sometimes they would ask for NTRKs. But now with PDL1, of course. But now NGS first option A type has a broader. People are shifting. The clinicians want a broader panel for lung, which comprises of the latest NCCN targetable markers, the EGFR, ALK, ROS, RET, NTRK, BRAF, KRAS, HER2, and MET. So this panel we have by 12 gene lung cancer. Also, if they turn out to be negative, now we are seeing a lot of comprehensive genomic profiles coming in for lung. So a few case studies that I have, I would like to say 65-year-old male presented with lung mass and was diagnosed with poorly differentiated carcinoma. On it further testing, it came for only EGFR, ALK, and ROS1 and turned out to be L858R positive. On follow-up, we got to know that though gefitinib was given, but there was no response. Then the person was retested for a broader panel, which comprised with BRAF, MET, RET, ERBB2, and KRAS. And we found in that there was MET exon 14 skipping. And this is how an integrated genomic viewer looks like, wherein you have forward as well as reverse strands. And if you look at the joining of the two tiles, the pink color tiles, it is clear. So the fusion is formed, and this is a good IGV for the patient to show that yes, there is a skipping of exon 14. This case was also cross-checked on fragment analysis, which is more sensitive to compared to NGS for when it comes to MET exon 14 skipping. Coming to case 2, 62-year-old male diagnosed with invasive carcinoma, again tested for a smaller panel and had ROS1 rearrangement. It was started on crizotinib, but there was no response. Later on broader spectrum, we found that there was KRAS mutation in the case. And this was the ROS1 rearrangement. Then the patient had been tested with a broader panel. Of course, the ROS1 was also positive with it. Likewise, showing an IGV with a fusion area clean, and it is a good IGV. So here we can see that the KRAS mutation and the ROS1 rearrangement, it is a rare, found in nearly 3.2% of the cases. But yes, sometimes a broader spectrum testing at the first step can help you decide the treatment well without wasting more time. The case study 3, 39-year-old female diagnosed with lung adenocarcinoma around a decade back. Again, L858R was positive. Started on gefitinib, but no response. Then again tested for ALK rearrangement only. It was started on crizotinib. There was good response, but there was a recurrence. So the patient was started on alectinib, but now there was no response. Now, what other thing that we should be looking for? It was the ALK resistance mutation G1202R, which was reported, and that was previously, that was maybe the reason the patient was not responding. So, in nutshell, I would like to say it is not only the DNA, not only RNA, but yes, a broader spectrum comprising of both DNA as well as RNA can help decide the treatment for the patient. Yes, there are cases when there is no pathogenic mutation. So maybe tomorrow in future we have data and it is targetable. So such cases can go for another broader panel, which is comprehensive tumor profiling assay, that is OCA+, which has 500 plus genes and with a TMB MSI score and a GIM with HRD score as well. So summing up, thank you.
Thank you so much, ma'am, for such a illicit talk. And I think you have rightly shown few examples also. And in the era of precision medicine, when we have so many newer drugs in our paradigm of treatment, I think it's very important to select a test with the right methodology and the right technique to decide upon and picking up the mutations and the fusions so that the patient can get the best drug upfront and not missed on because they have only one chance. So, routinely, are you doing both DNA or RNA in
Yes.
your
Yes.
lab?
Yes.
Or is there any other scenario where only RNA is preferable and not DNA?
No, sir, we do it with the DNA only. We do not do any test that is only RNA. Yes, when it is MET exon 14 skipping, then you know that it is there, then we cross-check the same with only RNA, which is on a different platform, fragment.
So ideal is to combine DNA and RNA together for the test. Do we have any other questions from the attendees? Okay. Thank you, ma'am. Thanks for your time. And for now, shifting from diagnosis, from testing to the latest updates. And for that, I would request Dr. Naresh Somani, sir. He is Director Oncology and HOD Medical Oncology at SCG Cancer Center and Somani Hospital, Jaipur. Sir will be taking us through the updates from the ELCC 2024, that is European Lung Cancer Congress, which was held in Prague in March last month. So over to you, sir.
Good evening, everyone, and thanks to Dr. Ankit Batra to give this opportunity. And as many of you must be aware that we keep doing many webinars and we keep updating about the various important meeting. So very recently the ELCC was done. And when I was going through the program of a 60-page flyer, obviously we cannot cover each and everything. So I just try to capture few of the important things which probably we are practicing presently, but maybe the refinement, maybe the positive and negative trials both, but I thought maybe of some importance for us. So I will only be giving the brief outline and the update and the conclusions. We cannot go through these trials in just 15 or 20 minutes, but just to give you the flavor that these are probably the important points, which if you are interested, you can go through in the detail so that you can understand them well. Now we talk about the flora and then we talk about the flora 2 and we have
Sir,
the
sorry for interrupt you. Make it full screen, please.
Oh, I need to make it full screen. That's perfect. Is it okay
Yes,
now?
sir. Yes,
Yeah.
sir.
So we talk about the flora and then we talk about the flora 2 and we understand today that flora 2, that is the chemo plus osimertinib in the first line, is probably the standard of care and is being now approved. So what happens after the flora 2, that is the post progression of this, what is the outcome? So that is about the flora 2 post progression analysis, and we know that it is the chemo 4 cycles plus osimertinib concurrent to start with in the EGFR positive patient, whether it's the DEL19 or L858R mutation, followed by osimertinib as well as pemetrexed maintenance. So that was this particular trial, and the primary endpoint was the PFS. Now the post-progression time for the first subsequent therapy and time for the second subsequent therapy in the PFS, that is the post-progression analysis was done. And on these particular parameters, it is the FLORA2 which has given the outcome benefit in the various parameters, and it has reconfirmed that yes, FLORA2, that is the chemo plus osimertinib to begin with, has shown the importance, and probably this should be considered as the treatment of choice presently, especially in the fit patient, probably in whom you feel that they can withstand the complications or the side effects coming out of the combination of the TKI plus doublet chemotherapy in the very beginning. Now, Pacific trial, we keep practicing since last 5 years or so. That is the chemo plus RT in the stage 3 inoperable patient who are suitable for the local therapy, followed by immunotherapy durvalumab in a specified period of the time. So, to understand what is the best time to start the immuno-oncology drug concurrent with the chemoradiotherapy, the Pacific 2 was designed. That is the concurrent chemoradiation plus upfront durvalumab. And then continuation of the durvalumab at the maintenance therapy in the unresectable stage 3 patient. This is the schema of the trial. So simply it is the shifting the immuno-oncology drug from the switchover from the post-chemo RT to the upfront along with the chemoradiation therapy. And this trial failed to show the benefit of shifting the durvalumab from the post CTRT to the upfront CTRT, and probably there is no difference except a subgroup patient like the female patient age less than 65, European patient, and the patient which have the smaller tumor size that is less than 450 centimeter cube. So probably a very small subset of the patient where it may be of some importance. So presently it is not considered important, and we go back to the Pacific only. So the investigators' conclusion was that the specific regime of the concurrent chemo RT followed by the durvalumab should remain as on today standard of care. And another thing which was being talked in the detail was about the mechanism of the resistance of the osimertinib in the first line, because now it's almost standard of the care to give the osimertinib with EGFR positive patient, those who can actually afford it. And the various mechanism of the resistance to the osimertinib which has been postulated depends on the kinase domain mutation and of EGFR or the independent mechanism of the resistance, including the lineage plasticity, that is the change in the histopathology like small cell or mesenchymal or non-adenocarcinoma type of the picture. And that is very, very important to understand, because still many of these mutations which are coming as the dependent on target or which are off target mutation, many of them are druggable, actionable, and we have the drugs for them. So that means that every patient is not only for the chemotherapy or chemo plus beva plus atezolizumab kind of the protocol. Many of the patients still may have the change in the protocol, change in the drug. So that is very, very important. Whenever the opportunity is being provided in form of that taking the tissue is possible, I think we should do a repeat biopsy to understand that what kind of the tumor mechanism it is going on. So that is being talked about, that if the rebiopsy, you do it. If the biopsy is not possible, try to do the liquid biopsy, do the comprehensive genomic profile, try to understand the histopathology, try to understand the types of the mechanism or the actionable mutations which are present. And if there are no actionable mutation, you try to treat the patient. So this talk was also being highlighted, and this was also being talked a lot about in this particular trial. So the conclusion was that the screen for the EGFR mutation, obviously, novel options are coming to the clinical practice. Choose your patients depending on the patient preference, logistic, efficacy, tolerance, and so many things. The another aspect of this patient is the Mariposa trial, which we all understand today, that in the treatment naive patient, it is the randomization between the amivantamab plus lazertinib, which is the bispecific drug, versus osimertinib versus the lazertinib with a single arm, to understand the contribution of the individual component. And we all know today that amivantamab plus lazertinib is better than the osimertinib in the various parameters, both PFS and as well as the extracranial PFS, though it is relatively toxic compared to the single agent TKI osimertinib. So coming to the Mariposa 2, which was also being talked in this particular ELCC, that was the locally advanced or metastatic NSCLC who have the documented EGFR positive patient, and those patients who has progressed on osimertinib as monotherapy as the most recent, which may be the first line, which may be the second line treatment also. So these patients were being randomized as amivantamab plus lazertinib plus chemotherapy doublet combination versus chemo only versus amivantamab plus chemotherapy. So 3-arm study was there. And important thing here is that amivantamab 3-weekly schedule is also being designed. So in our patient today, those patients who are exon 20 insertion mutation positive and getting the amivantamab in clinical practice, you can think of beyond the 2 weeks, that is making it, changing it to the 3-weekly schedule. So Mariposa 2 PFS, if we look at, it is the amivantamab chemotherapy versus chemotherapy. There is a difference in the outcome. Similarly, there is a difference in the amiva plus lazertinib plus chemotherapy versus amivantamab plus chemotherapy versus chemotherapy. But it's a toxic protocol. So more, what I will say that the various treatment options are available in this field, which are now expanding beyond the single agent TKI. So there is a more confusion, so many choices. So you need to be very, very wise in choosing your patient. So various options which are available to in the first line, like the first generation drug, second generation, third generation, like osimertinib, TKI plus chemotherapy, maybe the first generation TKI with chemo, maybe osimertinib plus chemo. And even we talk about the Mariposa also in this setting. So similarly, Flora 2 and Mariposa, they are the recent additions. They appear superior, but probably they are not for every patient. Toxicity is a big concern in this particular field. Another thing which I would like to continue in the continuation of the first talk by the regarding the NGS technique. So that was the cost effectiveness analysis of the NGS in the first line as the comprehensive genomic profile rather than as the reflect. And this particular data set says that it is cost effective to do the upfront comprehensive genomic profile rather than at the sequential methodology. Now the PAN2 is the another study where the plasma NGS only patients were being studied in a subset of the patient, and we know that every patient do not have the tissue. Tissue is a big issue. Sometimes the tissue is inadequate. Then we feel misery, we feel sorry, we feel frustrated for our patient after the end of the 2 or 3 weeks, that when we come to know that the tissue biopsy or NGS is not possible. So that was about the NGS. And now a new algorithm is being proposed, how to incorporate the liquid biopsy in the diagnostic algorithm of the upfront NSCLC, especially in the advanced cases. And that is being various ways to talk, that you do the tissue, then you do the sequential, or you take them the tissue and plasma complementary to each other, or maybe you take the plasma as the first line. So what people have proposed, I will say it's a proposal only, that in the very beginning, when the patient comes to you with a suspected clinical radiological picture of the NSCLC, you try to do the biopsy, but similar to that, don't wait for the reports. Start with the liquid biopsy, and simultaneously you do the further assessment of the patient by the biopsy, by the tissue NGS. And if your tissue diagnosis is there, your liquid biopsy is there, you probably need not to wait for the things. You can start the treatment. If the liquid biopsy is negative, you go for the tissue biopsy, knowing that the chances of positivity are less. And depending on the histopathology and the liquid biopsy report, probably you can go based on your PD-L1 reporting as the immunotherapy plus minus chemotherapy. So this is the proposed algorithm we need to practice in the certain subset of the patient, that it is algorithm like the biopsy, first do the radiology, then do the biopsy, wait for the report, ISC, then go for the tissue biopsy, wait. No, probably that may not be, a good option for each and every patient. Now, another failed trial which I would like to highlight here is the neoadjuvant osimertinib in early stage NSCLC patient. And because this drug is now approved in the adjuvant setting, this drug is a very wonderful drug in the advanced cases. So logically, it has been attempted in the pre-operative setting also. And presently, depending on the available pathological response rate, there is no difference in the MPR criteria in the EGFR mutation positive patient. So probably this drug should remain under investigation or in the setting of the clinical trial only if you are contemplating neoadjuvant treatment followed by surgery. So coming to the small cell lung cancer data, that is the 5-year survival in extended stage small cell treated with the Atezolizumab plus chemotherapy, that is IM power 133. So that is the first immunotherapy combination. We all know 5-year survival data are now available. So IMbrella-A is an extension study of this particular trial, where those patients of the investigational arm who were on this particular arm continued the treatment, they were further followed by giving them like the rollover to continue at the same treatment versus the placebo patient which has already stopped this particular treatment. So here we can see that this particular combination of chemo plus atezolizumab, when they are being given the atezolizumab as continuation, it is well tolerated. There is no extra side effects, and probably it is improving the survival outcome of these patients a little bit further. The median overall survival is 12.3 versus 10.3 months. So this is what being talked about this particular trial. And there is no new safety signals out of this combination. Now, few others also, in the constraint of the time, I would just like to say that consistent with many other trials of the immunotherapy, the perioperative tislelizumab also had shown the results in the RATIONALE 315 trial. The patient-reported outcome supported the first-line semiplimab, which is not available in India, plus chemotherapy plus ipilimumab, that is the doublet, The IO plus doublet chemotherapy in the Empower Lung 3 Part 1 trial also has supported its outcome. And another new class of the drug, that is DLL3 targeted bispecific T cell engager therapy, that is the TIDE therapy. Before probably it comes in the hematological malignancy, it is now making its footprint in the NSCLC also, and it has shown the impressive overall survival of 17.5 months in patients heavily pretreated advanced small cell lung cancer patient enrolled in this particular clinical trial. So that's a drug need to be carefully understood and probably the drug of the future in the small cell. So notable few other study was the Paloma trial. As we know that many available monoclonal antibody like the trastuzumab, pertuzumab combination and the drugs like the myeloma drug, dalatumab, and now this particular formulation, that is the amivantamab, is also being designed and developed as the subcutaneous preparation. The phase 1B trial of the various solid tumors, including NSCLC, has also been completed, and the results are probably matching with the available data. So that's the way that probably the monoclonal antibody in the future will change, will mitigate the infusion time, will probably decrease the infusion-related reactions also, making the healthcare burden less, making the patient's life little bit easier. Probably that's data coming out of the phase 1B Paloma trial also. So these are a few of the trials or the highlights I have picked up from the ELCC 24. Thank you.
Thank you, sir, for taking us through the updates of ELCC in a very crisp manner. And we all know that the treatment landscape of advanced lung cancer is changing very rapidly with the advent of various new drugs, be it TKIs or MABs or immunotherapies, and especially various permutations and combinations which are being tried. And recently, a lot of other TKIs have been there, but osimertinib is holding its fort very strongly. And before we change our practice on the Monday morning, I think we need to test this permutation and combinations in our clinical practice, in our set of patients, especially in terms of toxicity. And definitely in small cell lung cancer, the 5-year update of atezolizumab in terms of IMpower 133 and AMRAMRA is very, very impressive. And that 10% of the patients which are still doing well, we can definitely call them towards a cure. And with that, if any questions from the panelists, we can take 1 or 2 questions. If not, then we can move
One comment I would like to make here, that
Yes, sir.
combination of the osimertinib plus chemotherapy, the subset of the patient who have the co-mutation like P53 or the L858R population or with the heavy clinical burden of the disease, probably these are the subset of the patient in my mind where I will be enthusiastic giving the TKI osimertinib plus chemotherapy upfront.
Yes, sir, very rightly said. I think these are the patients which can be taken into consideration for changing this practice right away. And for rest, maybe we can have more data to support that. So with that, we'll move on to our next session, which is sponsored by AstraZeneca. And it will be on reinventing adjuvant therapy in EGFR mutation early lung cancer. And for that, we have our senior oncologist, Dr. Chandragowda. He's a director of medical oncology at BLK Super Specialty Hospital, New Delhi. So I invite Dr. Chandragowda for his session. Over to you, sir.
Thank you, Dr. Ankit. Thank you, Astra, for the opportunity. So without much ado, I'll just proceed to what I've been asked to do. That's reinventing the adjuvant treatment strategy in early lung cancer, so EGFR mutant early lung cancer. So when you talk of survival outcomes in resectable NSCLC, it is definitely changed a lot since the last few years. And what it used to be in a stage 1, 2, where the majority of them are resectable, 2/3 used to have a 5-year survival. When it comes to 3A, that ratio is reversed. Only 1/3 would survive for 5 years. So that's what was the survival rate. So what are the testing recommendations in the early lung cancer? So if it is a non-metastatic resectable lung cancer, we directly used to go ahead with the adjuvant, whether the patient is eligible for adjuvant chemotherapy or not. Now that scenario has changed. So with the advent of EGFR mutant, versus PDL1. So the patient is EGFR mutation positive, whether they have exon 19 del or they have L858. So whether they have EGFR mutation negative or the PDL1 positive is more than 1%, or both are negative. So depending on this, the adjuvant strategy would change. These are the current testing, the testing and the treatment pattern that we see in patients with the EGFR mutation. So what is the prevalent in EGFR mutations in patients who have resected stage 1 to 3 non-squamous NSCLC? This was published in ASCO 2023. This was paper presented in ASCO 2023. So if you can see that the overall prevalence of EGFR mutation is around 51% versus a wild type. So amongst these, the Del19 deletion was the most common, considering half of these, and then comes L858. So these two would constitute around almost 86% of the mutations. Less all others, T790 and the compound mutations would be lesser in frequency. This is the current testing and treatment pattern in patients who have prevalence of EGFR mutation stage 1-3 non-squamous cancer. Again, the same paper. So what you can make out here is that there are more than 2/3 of the patients on stage 1 to 3. The various bar diagrams, the blue one is the one which mainly constituted the surgical resection. So you can see the blue, which is more prominent amongst these bars, that more than 2/3 of these patients underwent only surgical resection. So from stage 1, 2 to 3, only 46.3 received an adjuvant system, only half received an adjuvant systemic treatment. So what happens if patient has been initially treated? So more than half the patient who have been resected, they have a recurrence within 5 years. So that's what is showing in here. So they may be either local recurrence or they may be a distant recurrence. So that actually is an unmet need. So to circumvent that to an extent, what has been done is that the adjuvant chemotherapy after surgery, for a stage 1B, 3A NSCLC, that improves an absolute overall survival by 5% at 5 years. So again, we initially when it's studying the size of the tumor is very more than 4 centimeters. How much is the benefit? What is an absolute benefit in trial? So where the absolute OS was around 5%, there was also a significant DFS benefit. So what about EGFR TKI in the adjuvant EGFR mutation, especially in the NSCLC setting? So when you talk of this, there are various trials which have been done in this scenario, and they are not, however, translated into overall survival benefit. Be it a SELECT trial, a RADIANT trial, EVON trial, or adjuvant CTONG trial, or BR 1.19 trial. So in all these trials, there is significant DFS benefit. However, there isn't any overall survival benefit. So this is what the meta-analysis of the same trials have shown. Yes, you can see the diamond on the left side as far the DFS is concerned. The OS in the EGFR mutant, though the hazard is 0.65, 64, tending, so that was not the endpoint they're looking at. They all resulted in the significant DFS benefit. So the risk reduction in the risk of disease recurrence, it differed by the timing and the sequence of the adjuvant EGFR TKI. The various sequence of chemotherapy, for example, somebody who received chemotherapy first and then the EGFR TKI. So all those points were considered in this. So why have these data not resulted in change in the clinical practice? The trial to date have not been limited by design and the size and other factors, and there is no OS benefit that is demonstrated to date. It's unclear if adjuvant EGFR TKI therapy results in cure or delay in recurrence. So there is no definite evidence on appropriate sequence, the drug at the duration of the treatment. So these are the unmet needs. So to address this, there's an ADAURA trial which was designed, and patients who have been completely resected 1B, 2, 3A NSCLC with or without adjuvant chemotherapy. These are the key inclusion criteria. The only patients who have non-squamous NSCLC with exon 19 del or L858 were considered. The brain imaging was done to rule out the brain metastasis, and maximum interval between the surgery and randomization was 10 weeks without adjuvant chemo and 26 weeks without adjuvant chemotherapy. So that's what was a randomization. They stratified into osimertinib, versus placebo. So the planned treatment duration was 3 years. So the continued till the disease recurrence, treatment completion, discontinuity criteria was met, and the follow-up was as given. The primary endpoint was disease-free survival by investigator assessment. The key secondary endpoints were DFS and the overall survival, the landmark DFS rate, and the OS safety and health rate quality of life. This is the Kaplan-Meier showing the DFS, improved DFS as in the primary as well as overall population. You can see at various time endpoints. So the osimertinib, the data is favoring osimertinib. So with hazard of 0.23, wide separation of the curves, and in the overall population also, it is showing that it's favoring the osimertinib. So this is adjuvant instrument has significantly improved CNS disease-free survival. As we all know, that this is a TKI which crosses blood-brain barrier. So hence, CNS metastases are the poor prognostic factors among patients with NSCLC and are associated with the deterioration of the quality of life. So the improved CNS efficacy with osimertinib treatment has shown greater penetration of the blood-brain barrier and higher exposure in the brain compared to the other EGFR TKIs. Adjuvant osimertinib is demonstrated the CNS DFS benefit versus placebo in both stage 2 and 3A and 1B, 3A patients. So this is ADAURA updated CNS DFS, the analysis as per the JCO 2023 favoring the osimertinib. There are no new any safety signals or any adverse events with osimertinib, as we all have used it, and it is a well-tolerated drug. So the key takeaway points are, in order to improve the survival, we need to put more efforts to identify lung cancer early. Never miss an opportunity to test for actionable mutation. Now this applies in early lung cancer also, especially for EGFR. The collaboration with the multidisciplinary team is key to improve survival. So patients may ask for treatment options for the best survival probability and be ready to discuss and offer them as per the best available data. ADAURA data gives a probability of patients remain cancer-free along with the survival benefit. Being cancer-free is a goal of patients as well as her treating physician. With that, I thank you all for your patient listening.
Thank you so much, sir. So we definitely know that last 2 decades we have been struggling in this space in adjuvant setting, and we have been juggling with the various permutation and combinations of first generation TKIs and chemotherapies. But now definitely osimertinib has strongly filled that space, and the focus of what needs to be given in adjuvant has now been shifted to what's post progression on osimertinib, and I'm very pretty sure that very soon we'll get that answers also in the molecular era. Do we have any questions from the panelists? So, yeah. Thank you, sir. Thank you so much for your talk. So, after witnessing about the TKIs and the molecular testing, we'll now move ahead to.
So, Dr. Ankit sir, can you please wait 1 or 2 minutes? Dr. Trivikram sir will be joining in 2 or 3 minutes.
Okay, sure.
Dr. Ankit?
Yeah, I think
Yeah, Dr.
Dr. Trivikram
Trivikram sir
has joined.
joined, sir.
Okay, okay. So welcome, Dr. Trivikram. Now we'll be discussing they're having a discussion about the TKIs and the updates from ELCC. We'll be discussing about our age-long backbone, that is the chemotherapy, and what newer advances have been taken in the formulations and infusions of chemotherapy. So we'll be discussing about InfuSmart, a revolutionary technique which is used to enhance chemotherapies in the patient care, and this session is sponsored by Sun Pharma. We have Dr. Trivikram Rao, consultant medical oncologist from American Oncology Institute, Hisar.
Thank you, Dr. Ankit, for the kind introduction. Sorry for the delay. So, Geetika, can you share the slides?
Okay, sir, Aram will upload it.
Okay. Yes. Yes. Hi, everyone. Good evening. Welcome for today's presentation. So basically, I'm going to discuss the novel technology that is the InfuSmart, so which is revolutionizing the chemotherapy administration. So disclaimer, next slide, please. Disclaimer basically is a Sun Pharma sponsored talk. So and at the outset, I thank Dr. Ankit and the event organizers and the sponsors for providing me this opportunity. So basically, coming to the talk, we all know regarding management of cancer, we have different modalities like chemotherapy, targeted therapy, immunotherapy, hormonal and supportive care. So the systemic management has evolved a lot over the years, but chemotherapy is still considered the backbone of the cancer treatment even today. So next slide, please. So basically, all chemotherapy involves reconstitution of the injectable chemotherapy. So, and this reconstitution has its own challenges, like the chance of contaminations, like the drug exposure due to the breakage or the spillage of the vial, to the staff concerned who is mixing the drugs, and the chance of needle stick injuries, then the diluent and the dosage errors. Many times it happens with the new staff. And it's also again a time-consuming process because it takes a lot of time for the drugs to arrive from the pharmacy to the daycare and then mixing again and then to bedside. So even though you want or not, there is always some delay in administration of the chemo. So this InfuSmart technique, which is a breakthrough innovation of Sun Pharma, it is a revolutionary patented technology developed by the R&D team of Sun Pharma. So it is nothing but a ready-to-infuse bags already diluted in appropriate quantities. It is a faster, safer, and smarter way to deliver chemotherapy. So the first drug which is available with this technology is gemcitabine in the ready-to-administer bag technology. Next slide. So basically, the package consists of, so this is very unique packing which ensures the safety and the sturdiness. So this is the outer carton, which is specially designed with the Kappa board box, which is consists of fibers with high mechanical strength and magnetic locks for easy opening. So also inside this carton, we have this aluminum bag, which is a special nylon-based overwrap pouch, which protects the bag from the punctures and the mechanical damages. Next slide, please. So the main bag, which contains the drug, which is a 5-layered co-extruded polyolefin bags, which is of high quality, which provides better flexibility. It has a special multi-layer high barrier film, and it has oxygen transfusion ratio and the UV light transmission. These coefficient all at well-balanced features. It also exhibits very low extractable properties. Again, the tubing or the pipe which connects, it has a 3-layered polyolefin tubing, which is a special tubing done to ensure there is no leak of the content in the bag to the outside. So bags are basically terminally sterilized in factory prior to the infusion in pouch and remain so till the end. So with this, there is also reduced chance of injection site pain because of the neutral pH in this premix solution. So in this, they have done a small study in which they have assessed the effects associated with the InfoSmart and to assess the pain in animal model through IV infusion. So the result is that mild irritation at the site of injection was observed in all animals with comparator gemcitabine, and there is no pain at the site of injection was observed with InfoSmart technology. So very small number, 9 rabbits, the comparator gemcitabine versus InfoSmart technology. The pH with the conventional vial, it is acidic to the tune of 3, and with the InfoSmart, it is neutral, that is 7. So to ensure that there is no irritation. So there is a busy table which suggests that, so they have tested this bag at different temperatures like 25 degrees, 30 degrees, and 40 degrees, along with different humidities, that is 40%, 35, and 25, and also at different temperatures again here at different concentrations. So what they found is that the solution of the InfoSmart remains sterile at different temperatures and relative humidity over an extended period of time. So this can be attributed to the fact that the solution is terminally sterilized in the autoclave before being filled into the bag. Also, the solution sterilized by filtration without terminal sterilization shows signs of instability and presence of particulate matter even when stored at conditions required by the parental products. Next slide. So this is the Indian map. So this is the Halol plant of the Sun Pharma. There's a manufacturing plant there. So what they have tested is that they make their bag travel. So from Gujarat near Vadodara, from the Halol plant to the Guwahati, from there to Chennai, from there to then Chandigarh and back to the Gujarat. So covering a total distance of around 8,300 kilometers. So basically, the objective is to evaluate the effect of temperature, humidity, and pressure variations on the quality of the bags during transportation. So, no, sorry, I'm back. So, back. So that whether these bags can withstand the atmospheric variations or not. So the result is that no physical hazard or damage was observed in these InfoSmart bags, unit carton or the outer carton. So these packs met full requirements to protect gemcitabine infusion bag during the transport. Next slide. So also this technology is patented in India. So this is the certificate for the Sun Pharma. Around 2012, they have got this patented. So basically what they describe is that any drug, any infusion dosage of gemcitabine comprising a solution of gemcitabine or its pharmaceutically acceptable salt in an aqueous vehicle filled in an infusion container, wherein the solution is present in volumes of at least 100 milliliters, and filled infusion container is terminally sterilized by autoclaving and is directly infused intravenously. So again, kind of similar description with aluminum overwrap pouch. So this is basically patented in India. Next slide, please. So also there is the list of other countries where gemcitabine ready to infuse bags are patented, along with the US, Russia, Austria, and other countries, total around 30 countries across the globe. Next slide, please. So also there is marketing approval by the renowned authorities like the US FDA and US, European Medicines Agencies in the Europe, DGCI India, and the TGA authority from Australia. So also, apart from gemcitabine, Sun Pharma has extended this revolutionary innovation to other molecule, that is pemetrexate. So coming with the name Pexitaz InfoSmart, available in 3 strengths, 700, 750, and 800 milligrams. Next slide, please. So it is available, like I have described, it's next, please. 700, 800 milligrams, and 750 milligrams in a dilution of 100 ml, ready to use infusion bags. Next slide, please. So this eliminates the drug wastage. We all know, based on the BSA, sometimes the total volume may not be appropriate for the patient's body weight and height. So they are provided in 3 different strengths. So this pemetrexate ready-to-use infused bags also has got patents and approvals in around 25 countries, starting from all European countries and India. Next slide, please. So it is a sturdy packing, ensuring safety till the end, almost similar to gemcitabine. It has the outer unit carton, which is specially designed box to provide the mechanical strength, and the aluminum overwrap, which is a special pouch which protects from the punctures and mechanical damages. and the pemetrexed ready-to-administer bag, which is a multi-layered bag with special tubing to ensure that is no leakage of the content. Next slide. So the storage requirements on the shelf life is that they can be stored at a temperature of below 25 degrees Celsius, and they remain stable for a period of almost 24 months, that is 2 years. So at this temperature. So the administration, like say, the single step administration saving time. We just open and just connect to the tubing to the patient. So it helps in avoiding the dosage and diluent errors, also eliminating the accidental drug exposure to the mixing staff, and it also ensures the sterility is maintained till the end of infusion. Next slide, please. So that's all. Thank you. Thank you all for your patient listening.
Thank you, Dr. Trivikram.
Thank you.
I think it's a very nice innovation by Sun Pharma, and currently we have 2 drugs in this form available that helps us to prevent a lot of human intervention, and definitely a lot of infections can be prevented. Just wanted to know your experience with this InfuSmart infusions.
So we have been gemcitabine have been using for last 3 to 4 years. Pexidarz I just started using for last 2 months. So good experience reduces the error rate because a lot of new staff coming, and somehow or other sometimes it's unavoidable that some kind of mixing error might happen. So very easy to use, and you just prescribe the strength you want, and there is no confusion that the dose administered is appropriate as per the protocol. So I'm happy with using this drug.
Yeah, I totally agree that once you have a lot of rotatory staff, it's difficult to handle and ensure the safety of the patient. So I think in those kind of setups, it is really very, very helpful, and it's a very good innovation by Sun Pharma. So thank you, Dr. Trivikram.
Thanks.
With that, we'll move on to one session on immunotherapy, and we'll be discussing about redefining the management of metastatic non-small cell lung cancer with the use of atezolizumab. And for that, we have senior oncologist, Dr. Deepak Gupta. He is a senior consultant medical oncologist at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. So over to you, sir.
Yeah, thank you everyone, and for giving me this opportunity. I'm just, I think my slides are visible now.
Yes, sir.
Yes.
All right. So this topic today is the redefining the management of NSCLCs with atezolizumab. So when we talk about the treatment options for metastatic NSCLCs who do not have any actionable driver mutation, so first line treatment options, multiple treatment options are available like chemotherapy, bevacizumab plus chemotherapy, or immunotherapy, chemotherapy combinations, or immunotherapy monotherapy, or triplet regimen like ABCP regimes. And when we talk about the second line treatment, so there are limited options because those who have been exposed to immunotherapy, second line immunotherapy is not used until unless it has been used, not been used in first line. Then we are left with second line chemotherapy or anti-angiogenic agent plus chemotherapy. So we will talk about atezolizumab in first line metastatic NSCLCs, and we'll focus on 3 trials. First one being the IMpower 1110, in which atezolizumab single agent was tested for both squamous and non-squamous NSCLCs as compared with chemotherapy as per the histology. And it was to test that is atezolizumab monotherapy is better agent than chemotherapy in PD-L1 selected chemotherapy naive patients. Then IMpower 130 in non-squamous NSCLC patients, in which atezolizumab plus nab-paclitaxel and carboplatin was tested against the same chemotherapy without atezolizumab, and this was to test whether this drug combination is feasible steroid sparing combination, better combination partner with atezolizumab. Then IMpower 150, which was again for non-squamous lung cancer. And in this, the triplet regime of ABCP or four-drug combination of ABCP or triplet regime of ACP was compared again, BCP regime of bevacizumab and paclitaxel. So this is the IMpower 1110 design, in which stage 4 non-squamous or squamous both were included, chemotherapy naive, PD-L1 were selected, more than 1%, more than 5%, or more than 50%. So there were 3 categories. EGFR and ALK should be negative, and stratification factors were gender, performance status, histology, and PD-L1 IHC expression. They were randomized 1:1 to atezolizumab, followed continuation till disease progression or loss of clinical benefit. And chemotherapy arm contained PEM-carbo for non-squamous and gem-carbo for squamous, followed by pemetrexed maintenance in non-squamous and best supportive care in squamous until disease progression. No crossover was permitted. Primary endpoint was OS in wild-type population, and key secondary endpoint were PFS, response rates, and overall response rates. So these are the demographic and baseline characteristics which are well balanced between the two arms. So primary endpoint of overall survival in high PD-L1 expression, that is TC3 or IC3 expression subgroup, was met. The median OS was 20.2 months as compared to median OS of 13.1 month, and which was improved by 7.1 month with a hazard ratio of 0.59. In TC3 or IC3 subgroup, the updated analysis, there continued to be clinically meaningful improvement in PFS, 8.2 month versus 5 month with a hazard ratio of 0.59 with atezolizumab, but it was not formally tested due to hierarchical testing plan. At updated analysis, overall response rates were also significantly higher with atezolizumab in IC3 or TC3 population as compared to 40% as compared to 28% in chemotherapy arm. OS benefit in PD-L1 high subgroup for atezolizumab over chemotherapy was maintained when it was tested by 22C3 DECO or SP263. All 3 testing platform with IC3 or more than 50% positivity had equal benefit with atezolizumab, with the hazard ratio being similar. And updated safety analysis was also consistent with the data presented at primary analysis. Grade 3 or 4 toxicities were significantly more with chemotherapy, and serious adverse events which were treatment related were also more with chemotherapy as compared to atezolizumab single agent. So in this cartoon, you can see that most of the toxicity like anemia, nausea, myelosuppression, vomiting, these were more common with chemotherapy, while immune-mediated effect like rash and arthralgia, pruritus, and hypothyroidism, they were more common with atezolizumab. So it was a positive study that demonstrated statistically significant and clinically meaningful improvement of OS in TC3 or IC3 wild-type population versus platinum-based chemotherapy. Atezolizumab showed meaningful improvement in PFS, overall response rates, and duration of response as compared to chemotherapy. And safety profile of atezolizumab was consistent with prior observation. No new safety signal was identified. Now coming to IMpower 130, which is a phase 3 study of chemotherapy with or without atezolizumab in first-line non-squamous. So stage 4 chemotherapy naive patient with performance rate of 0 to 1 non-squamous patient were randomized to atezolizumab plus nab-paclitaxel and carboplatin for 4 to 6 cycles, followed by atezolizumab maintenance, and arm B consisting of carboplatin plus nab-paclitaxel 4 to 6 cycle, and there was option of switch maintenance to pemetrexed or best supportive care to be continued. Co-primary endpoint was PFS in intent to treat wild type and OSS in intent to treat wild type population. So this rationale for combining Tecentriq with nab-paclitaxel versus paclitaxel, because the nab-paclitaxel is a solvent-free formulation that does not require steroid-containing pre-medication, and steroids have potentially immunosuppressive effect and reduce the efficacy of cancer immunotherapies. So that's why it was chosen. So these are the baseline characteristics which are generally well balanced in intent to treat wild type population. PD-L1 expression high was seen in 20%, low in 28%, and PD-L negative was 50% of population. So investigator assessed PFS was significantly improved with addition of atezolizumab to carboplatin plus nab-paclitaxel. Median was 7 months versus 5.5 months with a hazard ratio of 6.4. And this PFS benefit was observed across all clinically relevant subgroup in intent to treat wild type population. Age, gender, performance status, smoker or non-smoker, and PD-L1 high or negative, they all had benefit with atezolizumab. OS was also significantly improved with the addition of Tecentriq to nab-paclitaxel and carboplatin. Median follow-up was 18.5 months and median OS was 18.6 months with atezolizumab versus 13.9 months with chemotherapy. And OS was also OS benefit was also observed across clinically relevant subgroups as in the PFS. Overall response rate and duration of response was improved with the addition of Tecentriq to chemotherapy. You can see that oral response rate was 50% as compared to 31%, and partial response 46% versus 30%. Median duration of response was 8.4 months versus 6.1 month. This is the safety summary. Again, there were little bit higher toxicity with the addition of Tecentriq. Grade 3 and 4 toxicities were 80% as compared to 70% with chemo alone. And treatment-related grade 3 and 4 toxicities were also 73% versus 60%. Treatment-related serious adverse event were seen in 23% with atezo and 12.9% with chemo alone. So it was this IMpower 130 met its co-primary PFS and OS endpoint and demonstrated a statistically significant and clinically meaningful benefit of 4.7 month OS and 1.5 month PFS for the atezo plus chemotherapy. And these benefits were observed across all PD-L1 subgroups. Atezo plus chemotherapy had a safety profile consistent with adverse event associated with single agent therapy, and no new safety signals were identified. And so this trial supports atezo plus chemotherapy as a preferred treatment option for patients with advanced non-squamous NSCLC. Now coming to third trial, IMpower 150, which is again for non-squamous NSCLCs. In this trial, stage 4 or recurrent metastatic non-squamous NSCLC, which were chemotherapy naive, and tumor tissue was available for PD-L1 status. They were randomized into 3 arms, 1:1:1 ratio. The control arm was carboplatin plus paclitaxel plus bevacizumab for 4 to 6 cycles, followed by bevacizumab maintenance. Arm B was atezolizumab plus paclicarbo plus bevacizumab for 4 to 6 cycles, followed by atezo plus bev maintenance. And arm A was the atezo plus carboplatin and paclitaxel. In this, bevacizumab was removed. It was actually planned to compare arm A with arm C to see if atezolizumab can replace bevacizumab or not. And in this arm also, atezolizumab was given after completion of chemo as a maintenance. So they were treated with atezolizumab until progressive disease, and in control arm they were treated with bevacizumab until disease progression. So these are the baseline characteristics which were well balanced between the two arms. The liver metastasis was seen in approximately 13 to 14%, which was a stratification factor also. EGFR mutation were seen in 11%. This was also a stratification factor. There were approximately 50-50 split between PD-L1 and positive and PD-L1 negative population. So there was a significant OS benefit with addition of atezolizumab, that is arm B versus arm C, ABCP versus BCP. Median OS was 19.5 months as compared to 14.7 months with a hazard ratio of 0.80. And overall response rate and duration of response were also improved with intent to treat population. So you can see that arm A, there were response rates of 40%, and with arm B, which is ABCP, there was 56% response rates. When we see about PD-L1 high, that is TC3 category, the arm B, which is at ABCP, had highest response rates of 69% as compared to 62% with chemotherapy. And with PD-L1 low also, the ABCP arm had higher response rates as compared to chemotherapy. And median duration of response was also higher in arm B, 11.5 months as compared to 6 months with chemotherapy. OS benefit was observed across all PD-L1 subgroups in intent to treat, arm B versus arm C. Median was in PD-L1 high subgroups, median OS was 30 months as compared to 15 months with chemotherapy. And in PD-L1 negative, the curves overlapped, but when we include all three PD-L1 positive categories, the benefit was maintained. Median was 22.5 months as compared to 16 months. Now, coming to EGFR positive patients in this trial who have failed on EGFR TKIs. So PFS curve was seen separating around 6 months, and median PFS was 9.7 months with ABCP as compared to 6.1 months with chemotherapy alone, with a hazard ratio of 0.59. And OS benefit was also there in arm B versus arm C. Median was 29.4 months and with ABCP, and 18.1 months with BCP arm. So there was continued clear separation of curve and OS benefit with addition of atezo to bevacizumab plus chemotherapy. But when we talk about arm A versus arm C, so there was no benefit was observed. So ACP and BCP are equivalent, while ABCP is better than BCP. OS benefit in patient with sensitive EGFR, sensitizing EGFR mutation with prior TKI therapy also. So those patients who had prior TKI therapy, the median OS was 27.8 months with ABCP as compared to 18.1 months with arm C. And again, similar, arm A and arm C had, they were similar. There was no benefit of arm A over arm C. Oral response rates and duration of response were also improved with bevacizumab and plus atezolizumab, which increased from 42% to 71%. And CR rate, which was 0% with BCP, it increased to 6% with ABCP. Another subgroup is liver metastasis. So clinically meaningful PFS benefit was observed for arm B as compared to arm C. 8.2 months is a median compared to 5.4 month with chemotherapy. And OS benefit was also observed in patients with liver metastasis when ABCP was compared to BCP arm, 13.2 months as compared to 9.1 month. But again, arm A and arm C were similar, no advantage of one over other. Overall response rates when coming to when we talk about liver metastasis, so it was also higher with ABCP, 60%, and 41% with chemotherapy only. So median duration of response was nearly doubled with addition of atezolizumab, 10.7 months as compared to 4.6 months. So these are the safety profile. So there was a higher proportion of treatment related grade 3 and to 5 adverse event and adverse event of special interest in arm B, which is expected due to additive effect of 4 drugs instead of 3 drugs. So grade 3 and 4 toxicities were 57% in arm B as compared to 49% in arm C, and special interest serious adverse event were 44% and 34%. Immune adverse event were rash, hepatitis, hypothyroidism, and hyperthyroidism, and pneumonitis, which were commonly seen. But no new safety signal was identified after combining with BCP. So to summarize, IMpower10 was tested for atezolizumab monotherapy in high PD-L1 expression in both squamous and non-squamous histology. Power 130 is atezolizumab with nab-paclitaxel and carboplatin in non-squamous histology to test for potential steroid sparing regimen. And PD-L1, all comers were included, even less than 1% also. And options in patient with comorbidity, especially renal function, diabetes patient. Power 150, in which 4-drug combination of ABCP was tested in non-squamous histology with all PD-L1 comers. Significant benefit was seen in patients who had progressed on TKIs, liver metastasis, and bulky disease. Thank you very much.
Thank you, Dr. Deepak. It was a very nice talk. And I think the use of immunotherapy and chemotherapy combination, especially the ABCP regimen, is very much underutilized in a clinical practice, especially in settings where there is no driver or actionable mutation in first line, or even if you have a mutation, then in second line. So it's definitely a very good regimen. Just wanted to know your viewpoint about the toxicity. That do you really see that in clinical practice in real world? It is
No, actually, what I am doing is, if patient is young and fit, then I use the full dose. Otherwise, in elderly patient, which most of the lung cancer patients are, so those elderly patient or comorbid conditions, I use 840 mg, which is another dose strength available for Tecentriq. And usually patient tolerates very well, and these toxicities are not seen except few hypothyroidisms or skin rash.
Yeah, I think that's a very well technique to use, that decreasing the dose of one or the two drugs, and then you can escalate as per the tolerance. So that is what
Yeah,
required
most of
in
the patients are on 840 mg in my
yes.
practice.
Yes, I think that is the most important required in Indian settings, because our patients are totally different as compared to the Western world.
Yes,
So thank you, Dr. Deepak. So we'll
thank you.
move on to our next talk. And we all know that CNS metastasis is very common in all those advanced non-small cell lung cancers who have a EGFR, ALK, or a ROS mutation. So we'll be talking about one of them. And for that, we have reimagining CNS mutation in EGFR mutated advanced lung cancer. For that, we have Dr. Vikas Goswami with us. He's a director medical oncology at Max Super Specialty Hospital, Vaishali. So over to Dr. Vikas.
Thank you. So, the slides are going to be visible, or I need to share them?
Sir, your
Can you
slide
take-
is not visible. You can
Okay.
run from your
Let me,
side.
I'll share. How do I share my screen?
Sir,
Have you given me the rights?
sir,
Yes,
I'm
sir.
just
Okay, just a second. I'm using a phone. Apologies for that.
sir. If you can permit, we can also share your
No,
slides.
I have access. Just a second. Okay. Are my slides visible now?
Yes, perfect.
Thank you. So, I'll be discussing about the CNS mutations in EGFR advanced lung cancers and how do we treat and what is the treatment comparison. So we know the incidence of lung cancer across the world, and we also know that amongst the non-small cell lung cancers, we have various mutations, and EGFR is one of the largest mutation set. As per the Western data, it is around 17% as shown on the screen, but Indian data differs from 20 to 50% across the demographic profile. So, NSCLC, therefore, we almost always do a lung panel test at baseline, and this is approved across the guidelines. And if we talk about the EGFR mutation prevalence, there is wide variation, and on the whole, they are on the higher side on the Southeast Asian and Indian subcontinent. So, patients with lung cancer have highest rates of brain metastasis. We also know that. And we also know that such EGFR have higher brain metastasis. So, patients with single brain metastasis usually, of course, have the greatest decline in quality of life compared to other site metastasis. Understandably so, because brain being a closed cavity rapidly deteriorates the quality of life. So brain metastasis in advanced EGFR mutations and advanced cancer. The brain is a sanctuary site, therefore most of the chemotherapy drugs do not cross it. Up to 40% patients with NSCLC with EGFR mutation will develop brain mets, and because of the blood-brain barrier, it offers a resistance to most conventional chemotherapies. So osimertinib from the very preclinical studies has shown a reasonable intracranial penetration, and as per the mouse experiments, the intracranial concentration of osimertinib was way higher than other TKIs in the preclinical studies. So, moving on to the clinical scenario, osimertinib, we all know that has intracranial penetrance, and I'll be showing some evidence in real world and the trial evidence for the same. So, osimertinib binds irreversibly to clinically relevant EGFR kinase forms, specifically exon 19, T790, and L858R. We know that, and selectively inhibits mutant EGFR kinase. We also know that it prolongs PFS and OS relative to first generation TKIs, and this has been exhibited in various trials. High blood-brain barrier penetrance and blood exposure relative to other TKIs is achieved against CNS mets, and therefore CNS metastatic patients have better outcomes when treated with osimertinib. So how does the efficacy of osimertinib compare with first generation TKIs? We know the FLORA trial. The FLORA trial basically was a comparison of standard of care with osimertinib, and the Kaplan-Meier curves start separating pretty early in both patients with known CNS mets or without known CNS mets. So CNS progression occurred in 6% patients versus 15% patients in patients receiving osimertinib versus standard of care, and therefore it demonstrated a superior PFS benefit regardless of CNS disease. So osimertinib had significantly longer overall survival compared to other EGFR TKIs at 24 months and at 36 months. So if we talk about 36 months specifically, the numbers were 54% versus 44% alive. So moving specifically to the intracranial PFS, we can see the Kaplan-Meier curves. Again, the curves start separating quite early. Both the arms, there were 61 patients for analysis for osimertinib versus 67 patients, and the hazard ratio was 0.48 in favor of osimertinib with p-value which was significant in terms of 0.014. In absolute numbers, the median follow-up of the numbers was 12.4 months versus 7 months. So CNS PFS was significantly higher with osimertinib compared with the standard arm, and CNS progression was also the CNS results were better by other independent analysis. So first-line osimertinib, therefore, not only had better outcomes, but it also subsequently delayed the need for subsequent therapies. 28% versus 9% continued to receive first-line trial drug at 36 months. So coming to some real-world analysis, rapid intracranial. So I'll be discussing one or two clinical case scenarios. So rapid intracranial response to osimertinib without radiotherapy in NSCLC patients harboring EGFR T790M mutation. So there are two case reports. First one is a lady who underwent right middle lobe resection, and subsequently she developed lung metastasis, and for which she was identified as exon 21 L858R mutation, and she was started on geftinib. And she took geftinib for 2 years and 11 months. However, she progressed, and subsequently she was given various lines of therapy in terms of pemetrexed, platinums, Tegafur, Bev, and taxanes, and erlotinib. Uh, and subsequently, she developed brain mets, and osimertinib was introduced as a seventh line therapy. And the patient was identified. The pre-biopsy showed that the patient had additional T790M mutation in exon 20. So there are some scan pictures on the slides which kind of are there to prove the point that on seventh line therapy, as early as day 13. Now, what is important is that there was a rapid response in this case. As early as day 13, there was not only clinical benefit but also a benefit in imaging. So, multiple metastases at baseline and complete remission of brain mets was there by day 13. And this was also there in the lung, apart from the brain. Second case is a 76-year-old gentleman smoker who had stage 4 disease, exon 19 mutation, was on geftinib for 4.5 years, followed by afatinib, followed by chemo plus Bev. Then subsequent lines of therapy, and osimertinib was introduced as a fifth line therapy. By this time, his ECOG performance status was 2. So on day 10, after administration of osimertinib, brain CT scan revealed remission of the single brain met in right parietal lobe, which was asymptomatic. And on day 14, there was benefit in systemic symptoms as well, in terms of decrease in pleural effusion and pleural nodules. So both these cases, again, day baseline and day 10. So both these cases are there to highlight that not only osimertinib is effective, but it is a rapid responder in some cases. I'm not saying that's a rule, but rapid responder in some cases. Then there is a third case report which shows complete remission of brain mets in a patient with EGFR mutated NSCLC treated with first line osimertinib without radiotherapy. So we all know that we do have an option of omitting radiation and giving osimertinib in patients. We may give 80 mg. Sometimes there is also data for 160 mg for a better blood-brain barrier crossing. So in this case, this was a 74-year-old lady who was diagnosed with CA lung, exon 19 mutation, more than 20 multiple asymptomatic brain mets with diameter 12, with a maximum diameter of 12 mm were detected, and osimertinib 80 mg was started, WBRT was deferred, and the patient started responding. Multiple asymptomatic brain mets with we can see are responding as early as 5 weeks of therapy. So complete CNS response was confirmed. Then intracranial outcomes of de novo brain mets treated with osimertinib alone in patients with newly diagnosed EGFR mutant NSCLC. This was a cohort study and retrospective study, basically showing the same message as shown in the previous case studies, that intracranial penetration of osimertinib is good, it is responder, and it is a rapid results are obtained with this. So in this cohort, basically 36 patients who had a median interval from brain mets to diagnosis, first line of 25 days, they were given an osimertinib and observed retrospectively, and 2-year overall survival was 80%. CNS progression rates at 1, 2, and 3 years post osimertinib were 21, 32, and 41% respectively. And lesion level local failure was estimated to be as low as 0.7 and 4.7 at 1 year and 2 year post osimertinib therapy. So because of this, the guidelines have, we all know that the guidelines have approved osimertinib as the preferred first line therapy for exon 19, exon 21, L858R mutation, though outside the scope of this discussion, but we can see other recommended schedules where osimertinib is now combined with pemetrexate plus platinums. Of course, we have other data of erlotinib and geftinib plus chemotherapy, which the data is there from Indian Tata Institute. So with this, I conclude the message of this study is that number one, we know that osimertinib is effective in first line. We also know that it crosses blood-brain barrier. But possibly what this presentation wanted to convey was there are case studies which show that the responders can be as early as 24 hours to 1 week. So with that, I conclude over to the organizers.
Thank you, Dr. Vikas. I think with the examples and cases you have shown, the message is very clear. Uh, Definitely, it's a very good drug to have an early response, quick response. And not only that, it helps CNS progression and prevention of development of CNS metastasis also, which we have not seen with other first generation and second generation TKIs. So that is a very clear-cut message with the upfront use of osimertinib in first line and to prevent the patient from developing a CNS metastasis, which we all know that very well that it decreases the quality of life very significantly, and then we need to use of radiotherapy, which also causes a lot of neurocognition dysfunctions. So definitely, it's a very good drug to prevent and to halt CNS metastasis. And also, your cases have clearly shown that the responses are also pretty well and fast. So thank you, Dr. Vikas.
Thank
We'll
you.
now move on to our the day, and for that we have sponsored by AstraZeneca, which is optimizing treatment decision in unresectable stage 3 non-small cell lung cancers. And for that we have Dr. Sajjan Rajpurohit. He's a senior director, Department of Medical Oncology at BLK Max Super Specialty Hospital, Delhi. Over to you, sir.
Thank you, Dr. Batra, and the whole team for organizing and inviting me for this talk here. So we now know that we have a new standard of care in stage 3C, which was a stage 3 non-small cell lung cancer, which has long been only treated with the suboptimal treatment of only chemo radiation, and most of the patients are recurring within 3 to 6 months. So I'll just drive you through what has changed in the management of stage 3 unresectable non-small cell lung cancer, starting with a case, Mr. X, a 59-year-old gentleman presented on 17 July 2021 with cough, weight loss, and for the past 3 months, no history of any comorbidities. Patient came with an X-ray showing a lesion and evaluated further. Next slide. On a CT scan, showed a well-defined upper lobe mass and lymphadenopathy with paratracheal and right halar lymph nodes. On PET scan, showed kind of an N2 disease and mediastinal and hilar nodes. Next slide, please. Was found to be adenocarcinoma lung. Brain was done for evaluation for surgical purposes and found to be of normal. It was normal, and the PD-L1 was 20% and EGFR was negative. Next slide. So based upon the clinico-radiological staging, it was found to be stage 3B. Next slide. Now, with the final diagnosis of adenocarcinoma, EGFR negative, we assume that these there were no other driver mutations. Stage 3B non-small cell lung cancer. Next slide. So the treatment options which we had was a concurrent chemoradiotherapy, which could either be concurrent or sequential, or there could be a possibility of an induction chemotherapy followed by definitive chemoradiation, or the other was consolidation therapy or a maintenance therapy. These are all the options which were available to us at that point of time. Now, if you just see the outcomes of chemotherapy, radiotherapy in stage 3B, the overall response rates across various trials have been in the range of 30 to 70%, and the median progression-free survival in this stage has been quite dismal. It has been just 9.8 months to around 11.4 months. That's as poor as having a stage 4 lung cancer. Next slide. And if you see chemotherapy, concurrent chemotherapy versus sequential chemoradiotherapy, there was the 5-year survivals have been almost very dismal, and comparable in both arms. Next slide. Most of the patients, they recurred uh, loco-regionally and also had rapid advancement in the other parts of the body. Next slide. So this patient was started on initial chemoradiotherapy, and radiation was given in standard doses by IGRT of 60 gray in 30 fractions, and we used concomitant chemotherapy with paclitaxel carboplatin for 4 cycles, which was completed by September 10th, 2021. Next slide. So the follow-up scan, you can see there was still some partial disease which was left, though most of the disease was responsive. Next slide. So there have been a lot of trials with adjuvant chemotherapy in the form of consolidation, and we have seen that additional chemotherapy in this setting with additional 4 to 6 cycles haven't been able to have any improvement in the PFS or the OS. So most of the adjuvant extension of chemotherapy in the adjuvant setting in these lung cancer patients have failed to have any improvement in PFS and OS. Next slide. So if you just see, yeah. So this area actually has been an unmet need for most of our patients, and to improve the prognosis further, strategies like increasing radiation doses, induction chemotherapy, consolidation chemotherapy have been evaluated by various people and have found no improvement in the OS on all these studies and meta-analysis. So immunotherapy was increasingly being recognized as a safe and effective option for adjuvant chemoradiotherapy. Next slide. So herein we come with the data from Pacific, which was a phase 3 randomized double-blinded placebo-controlled multicentric international study. It was a large trial, and the inclusion criteria were all the patients were stage 3, locally advanced, unresectable non-small cell lung cancer patients who had not progressed following the definitive platinum-based concurrent chemoradiotherapy, who would have at least got 2 cycles of concurrent chemotherapy, who are good performance status, 18 years or older, and had a reasonable expectancy of life more than 12 weeks, and where tissues could be available to the examiners. Total number of patients was 713, and the time duration from the last dose of radiation was 1 to 42 days. So this is very important, that the radiation should be started as early as within 6 weeks of the maintenance immunotherapy should be started as early as within 6 weeks of the last dose of radiation. And these were randomized either to durvalumab, 10 milligram per kg body weight every 2 weekly, up to 12 months, or to a placebo. So in a randomized fashion of 2:1. And the primary endpoints were PFS by independent review as well as overall survival. So it was really, I would say, a very daring landmark trial where they kept both PFS and OS as co-primary endpoints. Secondary endpoints were objective response rate, duration of response, safety and tolerability, and the patient-related reported outcomes. Next slide. Baseline characteristics were well matched. So the average age was around 64, and most of the patients in the arms, more than 70% patients were males, and then we had 70% patients were almost Caucasian or white population, though it was a multi-institutional, multi-centric, multinational trial. And based upon stages, stage 3A was 52% in both the arms. Stage 3B was around 45.5%. And so almost, I would say, equal distribution of stage 3 and 3B. And most of the patients were ECOG performance 0 or 1. And mutation status, almost 65% and beyond patients were EGFR mutation negative. Next slide. Now, if we just see the overall survival, we started seeing this clear separation of curves in this study early on from 12 months. And this clear separation of curves has continued at 5 years median survival. So if you just see the follow-up of these patients, we can see such a clear early separation of these curves, and the difference in the survival being maintained from the first year onwards in the tune of from 81.1% versus 83.1% versus 74.6% to being clinically and I would say statistically being significant even at 5 years in the range of 42.9 months versus 33.4%. So I think this is one area, there's one trial where the curves have remained to be separated and they've not close together in a 2 or 3 years follow-up, which normally happens with many of these agents, and then these tend to have no improvement in overall survival. So if you see durvalumab, the number of events, the median survival, the number of events were, the median overall survival was 47.5 months versus only 29.1 months. And I think this is one impressive trial where such an improvement in OS has happened. Very few trials would have such significant improvements in overall survival. So this one landmark trial, which has actually been a practice-changing trial in our, almost all clinicians have acknowledged this in their practice, and now it has become a part of the standard of care for stage 3 lung cancer patients. Next slide. And now coming to the progression-free survival. So again, the progression-free survival has a similar story here, whereas we can find that again, the PFS benefit also started early on and again continued at 5-year follow-up. So if you just see the PFS1 in durvalumab arm was 16.9 months versus only 5.6 months. So more than 3 times increase in the progression-free survival again shows that there are only few immunotherapy which would actually have a both improvement in PFS as well as in OS in any of the clinical scenarios. Whereas durvalumab is durvalumab study, which is in this study, has shown a significant improvement in PFS and OS, which has almost been double or triple compared to the placebo. Next slide. Now coming to the real world outcomes with durvalumab. This was again a spotlight data, and 332 patients who received durvalumab were analyzed, and it was found that that approximately 50% of the patients started durvalumab when the patient within the suggested period of 42 days after the end of this thing. And many of these patients actually delayed their initiation of durvalumab to more than 11 months. And and almost 40.5% patients received durvalumab for at least more than 11 months. So one thing I think I would like to add here is that it's very important for clinicians to start the adjuvant durvalumab as soon as the patient is fit after radiation. And the best thing is that most of the patients actually end up taking, almost more than 50% of patients end up taking durvalumab at least for the planned time of 12 months. The median follow-up was 17.5 months. Next slide. So the primary endpoints were time from the first it would be like from initiation of durvalumab to the start of the first subsequent cancer treatment, and the TTM was time from durvalumab initiation to the first date of metastasis or death in the absence of metastasis. So these were the two endpoints. Exploratory endpoints were both PFS as well as OS. Next slide. So if you just see here, we could actually find that 12-month time which was on durvalumab was almost in the median was not reached during the study period, and 12-month 70% patients remained on durvalumab without need for any second treatment, and even at 24 months almost more than 50% patients remained on durvalumab. Again, one more data analysis was that time to metastasis, again time to metastasis was during the study time was not reached, and again almost 67% patient had no metastasis at 12 months, and also at more than 50% patients also continued to be having any metastasis or death even at 24 months. Next slide. So this real world data shows that not only in trial setting where we had such excellent results in the PFS and OS, the real world data matches the trial results. And that's very important for clinicians to understand whether because when we select patients in the clinical trial settings, they are usually much fitter patients. But in real world, the patients could actually have much more variation in their overall clinical profile as well as the performance status. So very impressive real world data. Next slide. So the data from the retrospective observation study were consistent with the results from Pacific 1 to 3 and indicate that durvalumab is effective in the real world patients. And the median PFS reported here was 17.5 months, which was again, I would say it was almost matching the trial data of 16.5 months, and was aligned with the Pacific 3 data. And all other parameters were also quite similar to the Pacific. The Spotlight study shows that durvalumab after chemoradiation is effective and well tolerated in patients with unresectable stage 3 non-small cell lung cancer patients. So that the treatment benefit observed in Pacific can be translated to everyday clinical practice in many parts of the world. Next slide. So patient was
So your voice is not audible.
my slide is not moving. Can you just put the next slide?
Sir,
So
is
the
it visible?
Okay, yes, visible. So we could clearly show that there was only fibrosis which was left there, and the disease had become metabolically inactive at the subsequent scan of PET. Next slide. So there was a very good response to durvalumab, hence patient continued to receive the therapy, and X-ray showed clearance of the initial findings which we began with. Next slide. Patient continued to receive durvalumab, and 15 cycles of durvalumab were received. Patient came with complaints of chest pain. A PET scan was done. Next slide. So there was a lesion which was there, and the likely steps which in the next slide could be chemotherapy, chemoradiotherapy, radiotherapy, or immunotherapy. So there was a possible progression. So again, if the pattern of first progression is local, then we could actually decide based upon local treatment which could be given to these patients, or we could observe them. And the most common progression was intrathoracic progression compared to the placebo, where there was a more generalized, or I would say distant progression. Next slide, please. So if you just see here, durvalumab number of events compared to the time of first event was much longer, 25.2 months versus 9.2 months. Next slide. So the first subsequent therapy after discontinuation of durvalumab, in durvalumab arm, 41% of patients and 54% of patients in the placebo arm received a subsequent therapy, which was disease-related anti-cancer therapy, and systemic therapies could include platinum-based doublets, single agents, immunotherapy, target therapy, radiation therapy, or a combination. Next slide. Durvalumab was generally well tolerable, and there were not many, I would say, many side effects. But then, yes, patients could have pneumonitis. That was one side effect, which was any grade was relatively higher compared to placebo. The serious side effect was 29.1% versus 23.1%, and that was not significantly different from the placebo arm. Next slide. So a multidisciplinary approach gives best outcomes for patients with stage 3 non-small cell lung cancer. Chemoradiotherapy gives better outcomes than RT alone or chemotherapy alone. Consolidation chemotherapy does not improve outcomes. First and only approved immunotherapy to demonstrate a 5-year OS and PFS benefit. Durvalumab should be considered as a standard treatment option in all unresectable stage 3 patients who have not progressed on chemoradiotherapy, and durvalumab improves outcomes of all subgroups irrespective of the PD-L1 status or the EGFR status. So these are the key takeaways of the real world as well as the Pacific data. And this data makes it the new standard of care. I think now this has been already standard of care for at least more than 3 to 4 years. But now the adoption of this new practice has now gone from tier 1 cities to tier 2 to tier 3 cities. And I would, in my own patients, I have had a huge benefit of adding this drug to the adjuvant setting in the chemoradiation patients. So it has emerged as and now stands as the new standard of care for stage 3 unresectable non-small cell lung cancer post chemoradiation. Next slide. So I think that is it. And thank you so much for inviting me again. And I'm open to any questions if there are any.
Thank you, Surgeon sir. It was a very illicit talk. And I think, as you already told, there was definitely a very big unmet need in the management of stage 3 lung cancers because their survival and outcomes were as bad as stage 4. So definitely durvalumab in consolidation has tried to fill in that gap, but still we need to look upon that how we can improve further. Just one thing, sir, that in patients, because the trial has included the EGFR positive patients also around, I think, 5 to 6%. So in your clinical practice, do you still follow the trial or you try to look out any EGFR positive and avoid durvalumab there? Or you would like to wait for the LAURA trial to become mature till that time?
No, so in my practice, I'm very sure that even from the stage 1B onward, I'll be very sure to get my patient's lung cancer panel if possible, because if the patient can afford, we should right away always check for driver mutations. And for patients who are oncologically driver mutated, we all know that probably immunotherapy might not be the first choice for our patients. So in my practice, I tend to avoid using immunotherapy, either durvalumab or Keytruda or even for that matter, new adjuvant Atezo. So I'm not using immunotherapy in my such subset of patients. So around 30% of the patients I have not used such agents.
Okay, sir.
Yeah.
Do we have any questions from any panelists or attendees? Okay, so if you don't have any questions, I think we can close for the day. At least I would like to thank everyone for sparing their time out from their busy schedules on a weekday. And we all know that the treatment paradigm of lung cancers, be it neoadjuvant, adjuvant, consolidation, or in metastatic setting, is changing very rapidly, and we need to keep ourselves updated. So, with that, I would like to thank our sponsors, the pharma companies, so that they can keep us engaged and keep us updated for the newer evidences, trials, and keep us engaged. So, with that, thank you everyone for joining and sparing time out, and good night.
Okay, thank you so much, sir, Dr. Ankit Batra, and all the faculties and attendees. Can you please join day 2 tomorrow also? And thank you so much, Aram
Yes,
and
tomorrow
Texaco.
I invite everyone tomorrow for a academic discussion on breast cancer.
Okay, thank you